Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello, everyone, and welcome to part 2 of our very special clinical series episode, talking about suicide prevention and going through some of the things that we actually had spoken about last time, the healthcare provider's role, the basics. And now we're going to expand a little bit more on that. And of course, joining me is David Danino, who's with me for our first part. If you want to give us a little intro and say hello again to our listeners.
Yeah, sure. And if you're joining us, thanks for doing part 2. It's the real critical part of everything that we're talking about. So again, just briefly, my name is Dave Danino. I'm a licensed professional counselor. I was a director of counseling at a state university for about 38 years. I've done a lot of work in prevention, particularly suicide prevention and suicide postvention over the last several decades. The other part of my work involves crisis and trauma. I'm a first responder with the Red Cross as a disaster mental health worker. I'm the state lead for Connecticut and Rhode Island, but I've do a lot of local work for both states. But I've done such national events as the Sandy Hook school shooting, which happened in our home state, the Las Vegas shootings, Hurricane Katrina, Harvey, floods, too numerous to mention across the United States frequently. So that's a bit of my background, and certainly my passion is in training people both in the health care field as well as people who don't have credentials, just regular folks to understand signs of suicide and how to do an intervention. So we're going to talk about that today. Not everybody in healthcare, either in mental health care or healthcare services provided by nurse practitioners, MDs, PAs, et cetera. We don't touch suicide a lot, so it's always good to have a refresher about it. So that's what we're doing for you today.
Yeah, absolutely. And I love that you said, even for the non-licensed folks, because one of the things that we spoke about in part 1 is really how suicide prevention, these conversations that we're having, is for everybody. It is everybody's business. So of course, we know that we are speaking to our audience, right? Our audience of providers and healthcare workers and clinicians. But really something I wanted to make sure that we kind of underscore, right? Because it is an everybody issue. You're totally right in saying that. Now, one of the last things we left off with in our first podcast, part 1, was the healthcare provider's role. So I was hoping we can just pick up with that and just a review on what that role is, and then get down into some of these deeper concepts.
Great. Yeah. And just to kind of go over when we left off in part 1, it was about why and how healthcare providers should be included. Research and some studies have shown, obviously, that all primary care providers and people in all aspects of healthcare and delivering services are in a good and unique position to help identify people at risk. Do we ask the question always? Probably not. Should we? Probably so. And then what do we do when that question is asked and the answer comes back as a yes? So we need to know the intervention methods, not that you have to do a whole suicide evaluation of the person, because it might not be your direct field of psych or counseling. But what do you do with the answer, and how do you hand that off, and how do you help the person with that issue? So that's really important. So it's about the proper education for all of us on using suicide-specific skills to do an intervention, and not missing warning signs and risk factors. And they're not unlike asking other questions when you talk to patients. You ask about lots of other things in life. You ask about physical health, sexual health, home environment. It's in the same vein as that, and it should be asked in the same way. It's not an alarming question. And we'll talk about that in a moment. So that's kind of a little bit of an overview.
Excellent. Yeah. And the question, I'm excited to get to that point, because when we do talk about it, it is like an awkward question. It does feel a little strange, but I mean, quite honestly, we ask people if they've ever had an STI before. How many sexual partners do you have? And that's an awkward question in itself, but we'll talk more about that. What about some of the warning signs? Can you start to kind of talk to us a little bit more about
Sure.
those pieces?
We'll talk about what the talk about suicide is, what the behavior and the mood might be with the person. But in terms of warning signs, there's no single cause. There's not one thing that will lead to suicide generally. It might be a culminating thing in a history of things that happen to a person. Um, so we know that suicide can occur when stress it comes into people's lives. That's important, obviously. And there's another thing that kind of sits on top of those things we're going to talk about, and that's the issue of depression. And I think we mentioned that in the first 30-minute podcast we did. Depression can be an underlying theme. In and of itself, doesn't necessarily lead to a person wanting to die by suicide, but it is a factor, and it's a big factor when people suffer from depressive illnesses. So, and I said this leaving off last time, we want to take all signs seriously. So, and we know depression affects people differently. Lots of ways depression can impact people, and you probably, when you're screening people, are asking about that. What is your mental health like? Are you depressed, anxiety? And certainly in the United States today, most especially, stressors are on the rise around everything: the economy, civil unrest, the COVID issues really have heightened everybody's level of anxiety and sometimes depression. So
For sure.
so that's a little bit about the background to take all signs seriously, but I think, we want to jump into kind of four areas, which is when people talk the talk about suicide first, and then we'll look at behavior and mood after that. And it's pretty clear if people talk about suicide, you should be listening. So if they talk about killing themselves in any way, shape, or form, if people talk about being hopeless or the helplessness, I can't deal with this, the struggle's too hard, there's too many things. The confluence of everything coming into my life is just, it's too heavy to bear. I can't take it. They talk about having no reason to live, perhaps. There's nothing to look forward to. I lost this much in life, that much in life. And even if we look at natural disasters as a pinpoint, you might lose your business, your house, you might lose loved ones. And then, the feeling to go on might become very minimal for some people, particularly those that were compromised with maybe prior mental health issues or don't have the resiliency to kind of go on. And if people talk about being like a burden to others, I don't want people to have to come to see me in a hospital. I don't want this disease or this injury to last forever. I'm too old to care for. I don't want to burden my kids or my family. So if they talk about those things, we want to listen to each and every one of them when people start to talk about it. So a good question, obviously, if somebody says something, is like, would you, tell me a little bit more about that? And certainly as providers, we're on schedules every day. We got to get to the next thing. But when someone starts to talk about these issues that I just mentioned, when they're talking the talk, you've got to push the pause button on your day for at least a period of time to investigate that. It's really critical and important. I said in the first 30-minute podcast we did that it was about 40% of people who died by suicide had seen some kind of provider in a prior year. It could have been for a checkup, it could have been for a rash, it could have been anything, but they had been in to see a medical provider. So it's important that we listen carefully. So talk is really critical. The second thing, if we start to look at the behaviors that people exhibit, so talk, behavior and mood, the behavior, and I think we look for this as we deal with patients and clients. Looking at an increased use in alcohol or drug use, any substance abuse issue needs to be monitored. You would do that for general health care anyway. But when you put that inside of someone who the drug and alcohol substance abuse issue, you put that tucked inside of somebody wanting to die, drinking and acting spontaneously and wanting to die can be a very lethal combination. So if people talk about wanting to end their lives and they talk about processes that they might do that, searching for methods to do that, we want to be careful of that as well. So that's a behavior. Unfortunately, in behaviors, we find out post-mortem When we look at emails or website searches and what people collected, we look back, we don't look forward, but we need to be looking forward and asking those questions. And then the other things, when people withdraw from activities, and a behavior can be like giving things away, which is a kind of cliche. I gave all my stuff away, but it does happen. And people do start to park parts of their lives with people that they want to have items that they had to leave legacy or meaning for them. So it's important. If they're doing that, we want to know that behavior as well. And the other thing is like when we're interviewing patients or clients, are they isolating from family? What's their social network like? Did it shrink incredibly? Were they on all social media forums and then they quit them all suddenly? That's a change in behavior, again, that we want to take a look at. So talking about things, the kind of behavior that they would present. And then, the third thing that kind of dovetails into this is mood. And I think we're asking, regardless of the healthcare profession we're in, whether it's in the physical health side or the mental health side, we always ask patients and clients, how are you doing today? That's a good lead question, right? And it's an open-ended question. But fine is a great answer for everybody, but it might not be the real answer. So at times we want to maybe, well, what do you mean by fine? How about family life? How about work life? How about relationship life? Those kinds of things, being more targeted, as you would be if you were conducting an interview or a session with a person who had suicidal ideation and you're a clinician. You drill down into many different levels. But in teaching the masses, that's not your job. Your job is to identify whether they are suicidal and then to get to the point, which we will today, about how to make a referral and get them help. So the mood issues, certainly we talked about depression and anxiety. They're probably the number 1 and 2 leading factors for mental health issues in the United States. Sometimes depression is number 1, sometimes anxiety is number 1, but they're kind of sometimes wed together. So loss of interest again in a mood, again, withdrawing from social media, social circles that you have, irritability that wasn't there before. And if you see your patient once every year, you have your notes, but, sometimes you remember their demeanor. And, if Dave, for example, is usually upbeat when he comes in, he talks about, his dogs, the Red Cross and things that are going on. But now he's not doing that. And I look forward to his Red Cross stories, and he's not telling him anymore, whatever that might be. So being irritable, anger, maybe agitation in their life, and then, kind of a giving up in the mood or a relief that don't worry about me, everything's okay. That's a statement, but what is it reflecting? So you have to do a little more. And we're going to take a look at that in a minute or two, what it sounds like and what it looks like. So any questions that pique your curiosity there?
Yeah, certainly. One of the things that I'm thinking about, and you kind of ended with this, but I'm thinking about, when does the patient historian or anybody, an individual's historian come in, right? So to your point, I imagine that as a provider and even as a registered nurse, right, thinking about some of the patients that I've come across, sometimes this could be maybe your first or second, brief encounter with this person. You don't feel like you know them quite well. It's not a patient that you really know well in that way, but you've got that feeling, right? And maybe it's something that they said, or maybe it was their behavior. There was something about it, and you feel like, I don't know, something just seems different, right? And so in saying that, in my own perspective, when I think about where I was working, I think about pediatrics that had patients, that had parents, that had older siblings, aunts, uncles that I could pull on to talk to and say, is this normally how they behave? Is this normally something that they say? But in cases where you feel like, I'm not sure, and there isn't a historian here, there's almost a part of you that feels like, I don't want to be judgmental or freak them out and say, I don't know, I'm really worried about you. You're not behaving like I think you might be. How does that play in?
Yeah, great question. And the word is how much do you want to pry, and do we want to pry
Exactly.
really deeply? And my answer to that is yes. And I think it can be done comfortably by saying I'm not really feeling your answer. I'm sensing something else. Is there anything going on? Would you like to kind of expand on that answer a little bit? But I'm not feeling it. Is there anything happening in life that you really want to talk about? Just to be non-judgmental and to be comfortable when you wade into it. You don't have to get to the suicide question immediately, but if your inner feeling is telling you that something's there, it does not hurt to get to the question and be direct and like take all signs seriously. Take your intuition as a healthcare provider seriously and say, I'm just getting a sense of something here. Are you thinking about and we'll talk about this momentarily, but the language has to be, are you thinking about suicide or are you thinking about killing yourself? And we'll talk a little bit in toward the end of this about how not to ask the question so
Yeah.
you can be direct and get the correct answer. But yeah, I think you got to wade into it and pry a little more if your gut feeling's telling you, especially when you meet a patient for the first time or second time. You don't really have the whole grip on who they are. If they've been a patient for 10 years, you kind of know. But new people, you gotta, if you're feeling it as a professional, you're feeling it. So go with it.
Okay, that's good. That's good advice. And I'm, interested to hear asking the question, right? Because as we kind of talk about that, right, I think about saying, I'm not feeling that answer and I'm a little concerned. Let's explore this together more.
Yeah.
And I have to be honest, I have absolutely had, especially as a brand new nurse, absolutely had the experience of going through a screening questionnaire, working in the ED, asking the question and getting a yes. And quite honestly thinking, where's my manager? Where, I didn't know what to do because I wasn't prepared with any rebuttal. I wasn't prepared in that way.
Yeah. And not even prepared to say, okay, thank you for that answer and being so honest with me. And then
Right.
moving to the next step, what the next step is, because you're not going to do a clinical overview of are they actively suicidal or not.
Right.
That's where you have to impart help, even in the healthcare professions. You got to look toward other professionals. And we're going to talk about how you should be prepared on your work site and know those kind of connections and regulations, if you will, if there are suicidal patients. So it's great.
Yes. Talk to us about that, about, asking that question, because I absolutely have felt the
Well,
fear of this is a yes, and I don't feel prepared to help.
yeah, and we're going to go through some other some direct clues and indirect clues when people are actually indicating directly or indirectly their thoughts about suicide, and then we get to that big one that are really centers itself. How do you answer a yes answer? When
Gotcha.
yes comes, it's like you sit back and go, "Oh, I didn't want that answer. What do
You're
I do
totally
now?"
right. You're totally right.
Healthcare providers do it. People in all walks of life say, "I don't want that answer. What do I do now?" This is about preparing for it and getting training. These two podcasts will help you, but then it's about some more training and how to deal with it. So let me talk about the direct verbal clues, which are easy, and then the coded or indirect ones. And the direct ones, this is pretty easy. If you're looking at a person's health and you ask about the suicide question, depression, suicide, and they say yes, that's obviously an answer you have to react to. But clues that people give off in language to other people, maybe to providers, I decided to kill myself, but not in a forceful way. I decided to kill myself. It's like, well, I decided to kill myself, or I wish I were dead. I have no business being here. I'm going to die by suicide. People will say commit suicide. The term we like to use is I'm going to die by suicide. But I'm going to end it all. And a really big one is if such and such doesn't happen in my life, I've decided I'm going to kill myself. So whatever that factor is in life, like if my divorce goes through, if my divorce doesn't go through, if I don't get custody of the kids, if I get fired from my job, if I get kicked out of school, a litany of things that compound other things that lead people to things that would make them think about suicide. So if they're direct, you can hone in on that. The other areas are like more indirect, where someone say, I'm tired of life. I don't think I can go on anymore. There's too much stress. And really, in the last couple of years here in the United States, a lot of people lament about that. Like, how am I going to get through my financial well-being, my job, COVID, civil unrest, shootings? So much for everybody to carry. So it wouldn't be an uncommon thing for a person to say, "I'm tired of life." But if you're in a healthcare provider, well, you've got to dig a little deeper and see where that's coming from. Things like my family would be better off without me. Again, going back to being a burden, or I'm such a cause of pain and agony to my family because of my behavior, what I'm doing. I should just check out. Who cares if I'm dead anyway? Things like that. People who become socially isolated and don't have connections. I just want out of all this. These are indirect clues you're listening to now. Or I won't be around much longer, so you won't really have to worry about me. Those are things that when people say that, you want to say, what do you mean by that? Can you tell me more about that? Because it could be benign. I'm tired of life. I just can't go on with this. And then you ask the question, please tell me more about it. Well, my 401k tanked. I think I'm getting laid off. I don't know what to do with the kids during the day anymore. So it's a compounded bunch of issues that then would lead to like, well, how do you feel about that? And are you thinking about like suicide? Are you thinking about killing yourself? Most likely the person's going to say no. Just don't have the capacity right now to deal with all this. I don't have the resiliency. I don't have the bounce back. So it's really the direct and indirect is about listening. So
that makes sense. And in that way, right, those direct and indirect verbal cues, right? So in this scenario, just kind of that you named, someone's just kind of like airing out their feelings. And absolutely, I get that, right? And they said, no, like, I'm not really thinking about suicide. Right. I'm complaining out loud. You're hearing me. But maybe you hear that person do it all the time. And again, I think it's bringing me back to my pride. Like, at what point do I say, hey, this is the fourth time this week that you said something like that? Is it as easy as, me saying, I'm just concerned. You're saying it a lot. And I know you said, no, that you really are not thinking about killing yourself or dying by suicide. Yeah. But I'm concerned that you're saying this a lot.
Yeah, and you can say that comfortably, I think, by indicating that I'm really concerned about you. You said that several times. That means things aren't getting better. So maybe you can open up the discussion about how can we help things get better? What kinds of resources would you need to get better at what is not working? And you can only go so far, and we know this being health providers, because people can be very closeted about what they reveal, and they can be very, very good at it because they learn through their life to hide things. Lots of people that have issues in life tuck them away, and people, unfortunately, if they do die by suicide, say, I never saw that coming, and truly they may not have, because people tuck it away and they get good at it. I guess a kind of an analogy is a person who has a substance abuse issue that hides it for many years. From people they live with, from kids, from family, at parties, at social functions, they hide it, but it's there. And then eventually it catches up, but they're good at making up the excuses as to why their behavior is off, but it's not about alcohol or substance abuse.
Yeah, good analogy there.
Difficult. So that's, the behavioral and situational clues are important. There's many more of them. If you do get some suicide training at some point, some more in-depth training about that at your agency or your practices, you'll learn a little more about that. So, but that'll pop us into the thing you're really excited about, is the yes, getting the yes answer. And I say excited about because you want to have some tools to be able to bounce back and not put that look on your face that goes, oh my gosh, what do I do with this? Because if a person says, yes, I have thought about suicide, or they say, well, I tried last week, but it didn't work. Maybe they just took not enough medication to OD. So if they say yes, what do you do with that? This is an important part of this. So how do you get comfortable asking the question? The first thing you need to know, and it's a giant misnomer for everyone, whether you're in healthcare or not, is that asking the question will not put the thought of suicide into somebody's head. You cannot present that. It's just not true. If I were to say to you today, Jana, are you thinking about suicide? And you never had, the answer wouldn't be from you, I never thought about that. What a great idea. I think I will try that. It just doesn't happen. So the thought of wanting to die is either there or it's not there. So you have to be comfortable asking the question, knowing that you're not going to precipitate some action that might lead to somebody thinking about suicide. You have to remember this in asking the question, that not asking the question might have more dire consequences that you didn't ask when you had the opportunity and the person went on to die by suicide. So asking is overall the better option for sure. The other thing I can tell you, and if there's clinicians that are listening to this and any that provide therapy, psychiatric nurses, psychiatric nurse practitioners, et cetera, they will tell you. And in my career, I dealt with a lot of students that were I would say on the borderline actively suicidal for a long period of time. But every time you ask the question about suicide and somebody has it placed in front of them, you will see their eyes go to the ground generally and kind of like shoulders go down. And this is a sense of relief that people have, that somebody pinpointed what they're struggling with, but hasn't asked the question directly. And I know for the students that I've asked, they were almost like, thank goodness somebody understands where I'm at and they can help me work with this. That's where you want to be. So it often leads to a sense of relief when you ask the question, not a sense of anxiety, not a ratcheting up of like, yeah, I'm going to go out and do it today, because they're struggling. They don't know how to deal with it. They don't know how to ask about it. And they're in this bad place, if you will. So overall, and we're going to have some direct and indirect approaches here in a moment, but overall, how you ask the question is less important than you actually ask it. You got to get to it, and that's the key part. So a couple of things here. Less direct approach, getting to the direct approach, kind of warming up to it, so you don't go, are you thinking about suicide? Like you were saying before, right out of the gate, or do I do a little more engaging here? Do I engage them in a different way? So maybe, have you been very unhappy lately? Have you been so unhappy that you thought about ending your life? We're still not saying, are you thinking about dying by suicide? Do you ever wish you went to sleep and didn't wake up? These are some kind of introductory questions that kind of soften for people the next question, which becomes the direct approach. And the direct approach is just that. Are you thinking about killing yourself? Are you thinking about suicide? I prefer using, are you thinking about suicide? Have you thought about dying by suicide? And it's direct. And if the person was and wants to be candid and unload that, they will. And that's the hope. And most people do, because they're waiting for that opportunity for the door to open, say, I need help. So a less direct approach, warming up to it, and kind of a more direct, actually. So the direct stuff, have you had thoughts of suicide or thinking about killing yourself? Do you wish you were dead? They're right there. And it's really important to know that kind of as a secondary check. And again, if a person acknowledges that they're thinking about suicide or they have tried suicide and now they're in your office, this is an alarm to get more help. You don't have to be there to do everything. So if you're able to, you can go a little bit further and have that conversation about, do you have a plan? How have you thought about suicide? And maybe they'll express, I thought about stockpiling my pills. I have a weapon at home, which is very dangerous. I thought about hanging myself. I'm not sure how I'll do it, but I know I could look it up. I've had that answer online and figure it out. And I know it'll be painless. So this is some rumination about how I'm going to get there. That's an important signal that the person's in trouble for sure, whether they have a plan or not, and they thought about it. The other big question is, like, have you decided about when you think you might kill yourself? Like, is it like a month away? Because people plan the event to get things in order, sometimes not. But it's a little more drilling down, if you will. Not that you have to ask these questions, but you've got to get somebody who's going to get more information about that. Kind of other things that are common to ask, have you collected things to carry out your plan? Pills, rope, weapons, etc. So did I get anything ready to make the next jump into that foray of really dying by suicide. So directly and indirect, it's you should be comfortable enough to have the conversation if it's telling, and again, your intuition is telling you should ask more questions. But remember, by discussing all of this, you're not going to plant the seed of suicide in someone's mind. They either have it or they don't.
Yeah, and that's an important piece. Certainly, that is something that I have even heard just in my own profession and practice, that, you think somebody might be on the edge, so to speak, for lack of a better term, and asking them, there is a real concern that you feel like I'm presenting the idea to someone who already is in distress, and I don't want to put that idea on them. That is a very real thing.
It is a very real feeling, and that's why people are afraid to ask it. And that's why we have such programs. And for those of you listening, you should think about your agency or the hospital where you work, and do they have any kind of suicide prevention training? And there's a multitude of national programs that are available. I happen to teach in one called QPR, Question, Persuade, Refer. And these are evidence-based programs. There's mental health first aid, which you heard a lot about during the Obama administration. There's Safe Talk. There's lots of them. Some are long, some are short, but they're all evidence-based, and they help us think about asking that question for both licensed medical providers and lay people. Remember, we're all licensed professionals. We have a higher level to establish in terms of safety for any patient you're working with.
That's right.
So that's critical to understand. So
that's right.
So, get to the question. I think a key part here too, and this is the next thing, and we'll talk about risk and protective, and then just your intervention. But how do you not ask the question in capital letters? How do you not ask the question? And I can relate to you a story of a mom and a daughter that were interviewed about the mom's son and the daughter's brother, who was in the military, died by suicide. And they both asked him, "You wouldn't do anything stupid, would you?" They wanted to ask, "You aren't thinking of killing yourself, or you're not thinking about dying by suicide or committing suicide," as they probably would put it. And the answer, in hindsight, unfortunately for them, was that it wasn't a stupid plan for her brother or her son. It was a good plan for him to relieve himself of whatever those problems were that were so terrible that he thought he had to die by suicide. So here's ways not to ask the question: "You're not suicidal, are you?" Because no.
The answer for sure is going to be no, right?
Yeah. You're not suicidal, are you? And again, I'll reiterate: you wouldn't do something stupid, would you? Suicide is a dumb idea. You're not thinking about killing yourself, are you? These are closed-end questions. You want open-ended, and you have to be direct in asking about: are you thinking about dying by suicide? Are you thinking about killing yourself? And the key thing is, if you can't get to the point where you can ask the question, find somebody who can. And I understand that's not always possible. If you don't work in an environment where you have colleagues you could turn to, other providers that you can turn to, that's difficult. And if you're in a single person practice and you can't get to it, get some consultation when that patient leaves, but be sure that patient is leaving in a safe way. You want them always to leave in a safe way. So it's important you get to the question. And again, I want you to just kind of think back to the point I made before. When you ask the question, people find relief in it generally. So it's okay. And you said before, you ask them about sexual health, you ask them about very intimate parts of their lives when they present certain things. So you can go there with the same degree of compassion and care with the suicide question as you can everything else. So I want to move along a little bit, and the risk and protective factors, just say a little bit about that, and then intervention. So major risk factors, and this is all part of having the history. If you have a new patient, you're developing that. If you have an older patient that you've had with you for a while, you'll know some of those things. But if they had a prior suicide attempt, It's a risk factor. It doesn't mean they'll go on to complete suicide after that attempt. Often people with treatment and intervention go on and live healthy and productive lives, because suicide is it's contemplated in a window of time when everything gets heavy, and that kind of time frame that exists can be, and I think of it as a bell curve, something leading up to the crisis. And if we can catch it before it gets to the top of the bell curve, we can start to de-escalate it with therapy and with intervention and kind of reconciling what they can't deal with. So prior suicide attempt, drug or alcohol abuse is a factor. Prior mental health conditions or current mental health conditions. A lot of people who go on to die by suicide have an existing mental health problem. Access to lethal means, you learn that in school. If they have access to guns, most especially, which is the number one way to die by suicide, you've got to get those weapons out of the home or have somebody secure them eventually. And then, the linkage to if you know someone who died by suicide, or if you have family history, is a bit of a factor as well. So those are some risk factors. Protective factors become important. And I call this kind of like, after my training in suicide prevention, it's the wall of resistance. You got all those major risk things going on, then you get the protective factors. So here is suicide over here. Here's the protective factor wall. The protective factor wall is how people cope with their problems, problem-solving skills, resiliency, connection to religion, perhaps, and faith. That could be religion for hope and care, or it could be religion that says, my religion doesn't really recognize suicide, and it's a bad thing if I die by suicide, so I won't kill myself. Family connections, social connections, supportive relationships with care providers of all kinds. We know this is difficult in the United States for sure, but availability of physical and mental health care, if they have access to that or not. And then again, the limited access to lethal means. So those are protective factors. That's the wall that we want to set up to help people not to die by suicide. If you have a question, you can interject, or I'll go on to the last part, which is intervention.
Yeah, I think this question really might lean into the intervention, because, as we're talking through this, and I'm learning a ton, I have to tell you, David, after practicing as an RN and even asking these questions, a lot of this is like breath of fresh air to me. But I wonder, just even in your opinion and your practice and your experience, you can certainly talk to this in our interventions section here, but how have you handled patients? How can we handle individuals, patients who won't be forthcoming and say, yes, I am thinking about this, because there's a real fear that if I say yes, you're going to do something to me. You're going to lock me up. I'm going to go to jail, or in that room in the ED, or something's going to happen to me, and I'm not going to say it because then I don't want that to happen. I'm curious about that as we're talking.
Yeah, and there's an approach that you could use that's more gentle than that, because some people do have that fear. It's like, if I say I'm suicidal, you're going to get me an ambulance and I got to do a 3-day stay at the hospital, right? And generally, that does, even with people who provide mental health services, that doesn't happen, but a small percentage of the time. It's all about getting intervention in the plan to be well. So it's more about imminent risk versus risk. Imminent risk is like, I have a plan, I have a gun, I'm going to kill myself, I don't care anymore. Then we have to ratchet it up and say, well, look, I've got a call, and I've got to help protect you, and I want to be there for you and with you. So needing that support, even from any provider, is critical, because they don't have other linkages at that point that are helping them with this. And it really is about coaching the fact that, look, we want to keep you safe, and this is part of keeping you safe. If you go to the hospital, it's for a further assessment. It doesn't mean that we might stay there necessarily. You might be released, but we want to make sure that you're okay for now. And I want to help you look for those resources to be well. So it's about the longer term plan. Clinicians do this all the time that work with patients or clients that are suicidal. So it's about the gentle approach to it. And sometimes you just have to make that gut feeling. And I've done this in my career. I mean, it spans like 40 years now. But I have had people hospitalized through, in our state, we have to do it through the police. There's special categories that can do that directly in the state of Connecticut. So, and I do that in a gentle way, walking the person through, being in touch with them, but they have to go to the hospital because I can't let them go, because I've determined through my background checked about their ideation level that they are in line of direct harm, that they are going to die by suicide. It's kind of like they're going to go off and they could actually kill themselves.
That makes sense.
So you have to make it comfortable that it's not, you're going to be hospitalized. You're not crazy. It's a normal process, and often, I know it's kind of a silly analogy, but I said, if you were having a heart attack right now, would you like to go to the hospital and have them help you with it? And maybe in a day or two, you'll be out and you'll be better physically. So the analogy is, this is your mental health versus your physical health, but it's like, we want to take care of it,
Absolutely.
So you're like, yeah, I'd go to the hospital if I was having a heart attack. So of course.
That's a good analogy. That's good.
So let's talk about intervention before we go toward the end here. And my word to you is, whomever's listening to this, wherever you work, think about a person that would help you with a person that might be suicidal. Who could you call at this moment that would help deal with that factor? And we'll talk about other helplines and so forth in a moment. But if you're in an agency in a hospital, you should be able to look to the left or the right and say, I need some assistance with this. And I've done that. I mean, I've had colleagues call me in to a session and they'll say, look, I want to get our director in here and make sure you're safe. And then I'll get involved in a conversation and we'll have two heads instead of one, say, this is what we're going to do with this patient or this client. So think about somebody who could help you. It's imperative that you know your agency's rules for intervention, because somewhere buried in a policy and procedural manual is something about dealing with suicidal patients or clients. So you better know what the agency policy is. So you might want to think about checking that out. What kind of screenings are available and how you let people walk out the door from your agency or your facility. And be prepared to ask the question and be ready to refer. Referral becomes an important thing. If you're in a mental health field, that you're working with that, but you might utilize other resources. If you're in another type of health field, you would connect with mental health to have those assessment done, and you probably will work collaboratively with that. So here's what you need to know for the intervention. The key part is about getting help. So know your resources in your community. Who do I call? In our state, in Connecticut, we have a 211 system. So that can be, as far as information for getting help, long-term mental health treatment into medical facilities, that can be helpful. How you get help immediately, which is obviously 911 if that's necessary. And that is really at the top tier of calling anyone. And I mentioned before just about using your community resources. We certainly have the 1-800-SUICIDE hotline. It's 1-800-273-8255, 1-800-SUICIDE. But wait, there's more. Like the commercial. We now have, and you can see a little bit of it over my shoulder, we now have 988, which just was unveiled in July. So it's a new, and this is important, we had a suicide hotline, 1-800-SUICIDE. 988 is for suicide prevention and mental health crisis. So not only suicide. So if you have a person in crisis in front of you, don't be afraid to call 988 and start to get some assistance and referrals from them in your home state. It also deals with substance abuse issues. So if somebody's having a severe substance abuse problem, 988 is the number to call. Federal mandate, every state in the United States, to get help, differently trained than just the info line of 211. So differently trained to deal with suicide and mental health crisis. So that becomes important. Both of those have, when you call in, also have immediately a link for veterans that is kind of ticked up, if you will, because veteran suicides clearly are of concern. So, if it's acute, get a person to help, get somebody on the line, make the next step. If it's less acute, maybe you can engage other family or clergy or someone in that person's life to help get them that help, if you will. So it's really imperative that we make the linkage. And in Connecticut, I sat on the Connecticut State Suicide Advisory Board for years, and we have a marketing campaign both for suicide prevention and now 988. But our promo, if you will, is really linked to one word, one voice, one life. So if you're there for that person at that time and you could link them, you might be able to do that intervention and save someone from dying by suicide. So any questions that you have at this point? Maybe we could wrap up.
Yeah, this is fantastic. We've covered a ton of great information. I think this has been fantastic and really, really, informational for me. And I've been in practice for 15 years, right? So this is an important thing. I think it continues to evolve, and I'm glad that we continue to surface these conversations because it's for everybody. And you brought up perfect examples of what's happening now in the world that really is just causing a lot of stress and contributing to a lot of maybe new feelings, right, that we haven't really dove into. So thank you so much, David, for that. Is there anything that you want to leave our audience with before we wrap up?
No, I hope you got, the tip of the iceberg here, and it piqued your curiosity, and you might look around to see if either your community is providing training that's free, or if your agency or hospital is providing any training that could be minimal in terms of your time out of your day. Yeah. Some programs run an hour to 90 minutes. Some run 8 hours, like mental health first aid, but they all will help you be better equipped for dealing with mental health crisis and suicide. So do what you can.
Excellent. David, I appreciate you so much for joining me today for this amazing dialogue. And thank you everyone for tuning into our podcast. We certainly hope you'll join us again for another discussion. I'm Jonna Emil, and on behalf of myself and David, thanks for joining us, and goodbye for now.
Thank you for listening to and learning from this podcast CE activity. Did you know that you can listen, subscribe, and share elite learning podcasts on podcast platforms like Apple, Spotify, and Google? Subscribe on your favorite podcast platform today and never miss a new episode. To earn your certificate, follow the prompts to complete the CE activity.